Today's topic is acute myocardial infarction. How we treat acute myocardial infarction. Uh, there is a pharmacological treatment and non-pharmacological treatment. Non-pharmacological treatments intervention. So we are talking about the acute myocardial infarction. So in that case, thrombolysis is important stay in the treatment because we can save the life, but it is underused or usually later on stage or advanced stage. After 90 minutes, patient reaches to hospital and get thrombolized. There is a little will benefit rather than optimal benefit that is achieved within 90 minutes with a door to needle time. So thrombolytic therapy works by lysing the infarct thrombi in achieving reperfusion. They are reducing the infarct size and preserving the left ventricle function. So left ventricle function is preserved rather than going to the failure or reducing the infarct size because it causes the lysis. So lysis causes reperfusion and infarct size that have myocardium get infarcted get decreased in size. There is no possibility to normalize at all, but definitely there is a size is decreased. So preventing to land into the failure and mortality is preventable, that is improving survival. So most effective thrombolytic therapy regime achieve angiographic epicardial infarct artery patency in only 50% patients who is reaching within the 90 minutes. How procedure is indicated in these STEMI? Obviously, ST elevation myocardial infarction, acute MI cases. In other cases of ischemic stroke, brain, CVA, cerebrovascular accident is the second condition when patient is reaching within 4 hours of onset of stroke. Peripheral arterial disease, sometimes you have to use the peripheral arterial disease prevention for the embolization. And pulmonary embolism, when patient is in a decompensated right ventricular failure with pulmonary embolism and there is a widespread pulmonary embolism causing major obstruction with dyspnea, shortness of breath and oxygenation is decreased. In that case only pulmonary embolism thrombolytic therapy is indicated. It is important to know that several conditions that are contraindicated for thrombolysis. Medical management thrombolysis is contraindicated. If patient have hemorrhagic stroke, within a year, patient having a history of hemorrhagic type of stroke is contraindicated because there is again chances of hemorrhagic stroke during thrombolysis. Second is a history of any stroke, CNS damage or dementia, but there is no absolute contraindication but relative contraindication, but absolute contraindication is a hemorrhagic stroke. Head trauma or brain surgeries within 6 months is an absolute contraindication. Non-intracranial neoplasm because neoplasm in the brain may cause hemorrhagic. Internal bleeding within 6 weeks, within a month, if there is any type of bleeding, internal bleeding, either it may be simple piles. Thrombolytic therapy is contraindicated. Non-bleeding disorder like a hemophilia, any coagulation disorders, traumatic CPR within 3 weeks. Sometimes patient comes to an emergency with cardiac arrest and there is a CPR and after revival patient goes in an ICU and up to 3 weeks there is a contraindication for thrombolysis. Patient obviously or oral anticoagulants like a patient of mitral stenosis or valvular heart disease already on the warfarin. In that case also Anticoagulation therapy in the form of thrombolysis is contraindicated. Pregnancy obviously contraindicated. Infective endocarditis and cavitation pulmonary TB. These are three relative contraindication according to benefit and hazard. So in that cases we plan PTCA. These are some contraindications of thrombolysis. In that cases PTCA is an option. Percutaneous transluminal coronary angioplasty, that is a minimal invasive procedure to open up blocked coronary arteries, allowing blood to circulate in the heart muscles. So stenting is either in primary or it may be secondary. In the primary there is a PTCA. PTCA means once there is a primary angioplasty, this patient comes to you, patient is in a stable condition, you are planning for the PTCA after 1 or 2 days. Once patient have thrombolysis and then plan for PTCA, that is secondary PTCA. After thrombolysis, if there is a condition is deteriorating or there is a contraindications, then you are planning for PTCA, the secondary. So once a primary angioplasty, secondary angioplasty is maybe an emergency PTCA. So indications: primary angioplasty is patient with double vessel disease. There are 3 coronary arteries. If there is a 2 coronary arteries involved, or there is a tri-vessel disease, or 3 vessels are involved, or double vessels are involved. Sometimes some branches of the there is a 2 coronary artery, left and right. But left coronary artery have a division in the left anterior descending artery, that is the main, and others are branches. So there is a 3. If there is a 3 vessels disease, left anterior descending, along with this a circumflex or right coronary artery involved, there is a 3 vessels disease, or there is a left anterior with other coronary artery, there is a double vessels disease. Or sometimes there is a single vessel disease like either right coronary artery or left coronary artery itself, main stem, or there is a branches, that is single vessel disease. So PTCA is indicated double vessels or triple vessels disease. Single vessel disease usually not preferred. Either there is a significant involvement of the myocardium. So patient with single vessels or double vessel without significant proximal LAD, but there is a viable myocardium involvement is large in the single vessel disease also. So double vessel disease and triple vessel disease with significant proximal LAD at the main stem, who have anatomy suitable for catheter-based therapy and normal LV function and non-diabetic. So there is a clear-cut stable patient having normal LVF, left ventricle function is normal, and patient is non-diabetic. We are talking here the diabetic because diabetes patient usually have a chances of involvement of the more coronary arteries, and there is a chances of more stenosis, and there is a large myocardium is involved usually. So non-diabetic with normal LV function is suitable for the PTCA. And patient with single vessel disease or double vessel disease without significant proximal LAD, main stem is not involved, but whatever the coronary artery is involved or branches of coronary artery causing the large area of myocardium is involved, having a high risk criteria, is also suitable for the PTCA. There are some complications that may occur during the procedure or after procedure are the hematoma at the incision site, replacing the catheter, pseudoaneurysm, embolization during the procedure, hypersensitivity to dye, restenosis immediately or within 3 to 6 months. There may be chances of arrhythmias. There is a most common complication during procedure. There is a chances of arrhythmia during procedure or even just after the procedure. Vessels rupture. There is a rare chances, but there may be need for CABG again. Angina, MI or vasospasm during procedure. Abrupt closure of the dilated segment, or there is a coronary artery dissection. So these are the complications that may see during the procedure or just after the procedure within a month. In that cases, CABG is the ideal choice. Coronary artery bypass graft. There is a surgical technique and use saphenous leg veins, internal memory artery as a graft to bypass the obstructed portion of the coronary artery, and there is a ligation to anastomatize to the other patent coronary artery. Because this is bypassing the obstructed portion of the coronary artery, that's why it is not a coronary artery bypass graft. It bypasses culprit vessels, and CABG is classified as a single bypass for the single vessel disease or double bypass for the double and triple bypass for the triple vessels disease. So CABG is useful whenever there is a complication of the PTC or PTC is not suitable. In that case, usually double vessel or triple vessel disease having complication during procedure or without procedure going for the PTC is ideal for the CABG. So keep in mind, triple vessel disease, if patient is a diabetic, always go for CABG. So indication: patient with significant left main coronary arteries, patient with triple vessel disease with ejection fraction, it may be less than 50% or more or equal to the 50%. Patient having double vessel disease with significant proximal left anterior descending artery and either abnormal ejection fraction or there is a demonstrable or non-invasive testing. So LVF is compromised in all the cases. Functioning is compromised of the ventricles with double vessel or triple vessel disease. But it may be indicated in the single vessel when there is a left main coronary artery is involved. If the whole left main coronary artery is involved, then CABG is only indication because PTC will not work. So these are the three indications for the CABG. Now CABG itself has some complications. In the post-perfusion syndrome, there is a transient neurocognitive impairment associated with cardiopulmonary bypass. Incidence is decreased by the off-pump coronary artery bypass, but with no difference between 3 months after surgery. The meaning of this concept is post-perfusion syndrome means whenever we go for the coronary artery bypass, we use the cardiopulmonary bypass machine. At that time, there is a chances to supply to the brain is decreased at that time. That's why there is a neurocognitive impairment is seen that remains maybe up to the month. Beyond that, there is a no post-perfusion syndrome, maybe other etiology. Myocardial infarction during the procedure due to the embolization of the fragments. Hypoperfusion, at that time there is a perfusion is depressed. Graft failure. Elevation of the myocardial CPK-MB enzyme more than 5 times the upper limit of normal is commonly diagnostic at that time of myocardial infarction. If patient is going for the CABG and at that time patient is advised for CPK-MB, if CPK-MB is more than 5 times, that indicating patient is in an acute myocardial infarction because of embolization. Either it may be embolization or there is a hypoperfusion or there is a graft is failed. Arrhythmias may be seen in the form of most commonly is atrial fibrillation. This arrhythmia is most frequently complication because it 40% patient primarily within 2-3 days. So beta blocker is used just after the surgery to reduce the chances of the atrial fibrillation. because sympathetic stimulation usually seen after the CABG. So if not contraindicated to beta blockers, use beta blockers. Late graft stenosis. Obviously there is a graft and there may be stenosis after some time. So particularly of the saphenous vein graft is usually atherosclerosis. So chances of myocardial infarction is recurrence is there. So internal memory graft is usually used rather than saphenous vein, but saphenous vein is harvesting is more easier. Acute renal failure may be seen due to the hypoperfusion again, because embolization or hypoperfusion is stopped due to the hypoperfusion. Pneumothorax, hemothorax may be seen. Pericardial tamponade, that is important. Sometimes there is after the surgery. There may be rupture and then blood collected around the heart and compressing the heart. There is a brain perfusion is decreased and patient may go neurocognitive disturbance. Churches should be placed at that site. There is a surgical complication. Pleural effusion that leads to hypoxia, vasoplaque syndrome secondary to the cardiac graft, and hypothermia that remains up to 15 years. And after these procedures, the important part comes the rehabilitation. So cardiac rehab is a comprehensive therapy combining prescribed exercise training, cardiac risk factor modification. So modifiable risk factors should be stratified and advised to curtail these risk factors. Educate the patient how the eating habits and the working hours and working habits that may affect their heart health, and how much the exercise they have to do after the surgery or PTCA or the thrombolysis therapy. Nutritional counseling and psychosocial support. Psychosocial support is also important once there is a cardiac surgery or cardiac stenting. After myocardial infarction, any patient they have a psychological pressure that they have the cardiac compromise. But nowadays there is advancement of the technique. The cardiac functioning is preserved and the medical management is also high level, so the patient may go like routine activity as others. So psychosocial pressure should be removed by the counseling. And the build confidence and get stronger that you have the surgery or medical treatment for a heart issue such as heart attack. That is a big issue. Heart attack, coronary artery disease, heart failure, peripheral artery disease, the chest pain, there is cardiomyopathy, coronary artery bypass, graft, angioplasty or stenting, heart or lung transplant. All these should be counseled patient. Patient should know each and everything. Exercise may do in cardiac rehabilitation can vary depending on the fitness level and the risk factors. If the patient is in obese, accordingly we have to prescribe some exercises. Aerobic exercise, and the patient conditions like patient is having a triple vessel disease, in myocardial infarction, having the LV function is less than 40%. These patients should advise for the simple exercises only. So aerobic exercise like walking and riding or stationary biking are usually elliptical or step trainer. Activities to strengthen your muscles like lifting feet, weight or using cable machine and resistance band. So there is two types of exercise, either isotonic or isometric exercises. So should be isotonic exercise that is advisable in that cases only. There is no use of the increase the muscle mass, but only the strengthening of the muscles. So other cardiac rehabilitation programs includes there is a eating healthier, stress management techniques, and staying at a healthy weight. Obviously, if patient is an obese, then weight reduction is an important part, and stopping the use of tobacco, alcohol, and other substances, and taking and managing your medicines, time to time take the medicines, and control blood pressure. If patient is diabetic, the blood sugar. If there is a dyslipidemia, there is a cholesterol should be managed. So it's all about the mm, acute MI management in the form of intervention and the rehabilitation.